You're watching Maximising the Educational Utility of the ECTV, produced by GP Supervision Australia and presented by Dr. Simon Morgan and Dr. Murray Luddington. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
How you as supervisors can really maximise the educational value of this potentially useful teaching method called the external clinical teaching visit. In many respects, this is quite a unique activity, and I've had the opportunity to talk to a number of educators around the world, and I do think it is something that's not done widely in other jurisdictions and something we obviously put a lot of emphasis on. And it's really a great pleasure to be able to engage with you about how to really make the most of this resource-intensive, this expensive, but potentially highly valuable educational activity for our registrars. My name is Simon Morgan. I'm the medical educator with GPSA. I'm a GP here in Newcastle. I'm joining you from a Awabakal country. And I would like also very much to introduce and welcome my co-facilitator, Murray Luddington. Hi, Murray.
Hello, Simon. Thank you very much for inviting me. I have been a practice owner and supervisor and examiner, and these days I do much less, but I do some ECT visits and some remedial registrar work and other odds and sods that come my way.
In thinking about this topic on teaching visits, I guess a lot of credit does go to Murray. Murray has been, I guess, an active contributor and consumer of GPSA education over the years, and got in my ear about the teaching visits as a supervisor, as a teaching visitor, about how we might help facilitate supervisors to really make the most of this potentially very valuable educational experience. So we're talking briefly about the ECTV as part of the workplace-based assessment program. Most importantly, how the teaching visit as part of the WBA can be incorporated into your role supporting registrars in practice. And we'll be talking a little bit about resources at the end. Just to sort of set the scene, I guess, most of you will be aware of this, but the RACGP and ACRM as well have both moved towards this so-called programmatic assessment in recent years. And this is an international push in medical education towards multiple low-stake assessments of the registrar as they progress through learning. We still clearly have a summative assessment at the end of training where a registrar needs to sit and pass the fellowship exams. But in order to get a sense of their competence and how that's progressing, we undertake multiple small assessments, which is this so-called progressive assessment. And clearly, this is assessment for learning, meaning we can give feedback and help fashion the registrar's development. And a part of that, of course, there's a reliance on lots of these WBA, workplace-based assessment activities. And they are, as the name would clearly suggest, based in the practice and designed to be very authentic because they're in the registrar's workplace. And this comes really from RACGP documentation, allowing assessment of clinical performance, allowing assessment of patient safety, and allowing assessment and development in these areas of the sorts of broad skills that we know are so important in general practice, like managing uncertainty and maintaining professionalism. And this will be my only slide with some theory in it. And this is a slide I've referred to many times, and it's very hard to give a talk on assessment without talking about Miller's pyramid. Hopefully most of you are aware of this and seen it in the past, but it is this hierarchy, I guess, of assessment methods and how we can truly assess competence according to the rigour of the assessment. And so we've moved after, I guess, decades in the past of assessing knowledge primarily right down the bottom of essentially this very clumsy and crude assessment of competence of just recalling facts, all the way up to what a registrar or a learner truly does in practice, and that is workplace-based assessment, performance in practice. And that's where, yes, of course, we still have MCQs and we still have written type exams like the KFP, but we are taking a focus on the top of this sort of competency assessment pyramid. what are the workplace-based assessment competency areas? These broad themes that the exams assess, but also these lower stakes, frequent workplace-based assessments also assess. And there's a reason I'm putting this up here, because I think as supervisors and indeed as educators, we often do very much default to 2 or 3 or 4 of these things. The clinical domains, how they might clinically reason and maybe diagnose and set up a management plan. And it is so critically important, I think, to have this broad focus when we're teaching as supervisors in the practice and in the context of talking to a teaching visitor, thinking about the registrar's performance in practice across this breadth of domains. This comes directly from the programmatic assessment resource from the RACGP. Basically, in practice observation of a registrar, an opportunity for the registrar to receive teaching and feedback on their individual performance and consultation skills from someone other than their regular supervisor.
One of my pet aversions are selfish registrars, the ones who come and want to squeeze as much out of the practice as they can and not give too much back. But I tell them in ECT visits, it's their moral obligation to be absolutely selfish and squeeze as much out of it as they possibly can. And it's a great opportunity to get some ideas from someone else and just see what they can get out of it. Not always an idea that they've got, that sometimes comes as something a bit new.
Thank you very much, Murray. I'm partly influenced by a comment that came from one of our supervisors, and it was actually a very strongly worded comment, which I'm very happy to speak to. And it was around this notion that as the supervisor, I know my registrar. I spend a lot of time with them. I sit in with them. I understand their strengths and weaknesses. And the word resentment was used, actually. It was, as I say, it was a fairly strongly worded comment around the visitor coming in and saying, this is what's going on, when in fact, hang on, they're just, this is a very brief window into the registrar's competency. And so actually, in finding this, I was very pleased to see that it is very much giving a nod to the regular supervisor, I think, being the person who probably knows the registrar best. And they're just providing another set of eyes. So I think that sort of a whole notion of respect for the supervisor's oversight and depth of interaction with the registrar is so important. That I was just taken with that definition. And the other point, of course, and I know, Murray, it's one that you have inquired about and one that the college, I think, are thinking about, is that whole notion of how much of the visit is teaching-based, how much is assessment-based, how much teaching and assessment may conflict with each other. This is very structural, very organisational, very practical. The teaching visitor will come in. The requirement is to assess at least 4 consultations and do 1 random case analysis, clearly to provide feedback to the registrar. As a teaching visitor of many years, sometimes that's really difficult when the consultations go on a long time and we're running behind, and that gets tricky, but that's obviously the most important thing, is to be able to give some feedback. Talk to the registrar a bit more broadly about how things are going in the practice, and then, of course, talk to the supervisor and the practice manager, if possible, about the registrar's progress and the reporting requirements being completion of a report. So that's really all I wanted to kind of touch on as the background. And you're all supervisors who are the recipients of teaching visitors in the practice and teaching visit reports and understand the process. What do you see as a supervisor as the primary purpose of the visit? So when the visitor goes away and they've had a chat to your registrar, are you hoping they've imparted a whole lot of knowledge and skills and really helped develop those things? Or is it mainly about assessment, so you've got an idea of how they're going? Or is it really a combination? And is there a tension there? What's your role in teaching visits? How can you enhance the educational value? What can you do on top of what you're already doing to make these things more valuable for the registrar and indeed your teaching and learning in the practice?
Well, there was quite a range of opinions as to whether it was primarily an assessment or primarily a teaching and feedback visit, and there was people with fairly firmish views at both ends. So different people see it quite differently. There was a fairly general comment about, look, it's just a fair bit of it's to see if the registrar is okay or not, and if they're not, then occasionally a registrar will be flagged. There was a fairly general recurring comment that it was useful for supervisors to see if the visitor and them are on the same page. It's good to have someone else someone else's perspective and sort of reassuring if the visitor was saying much the same things that you were thinking as the supervisor. And there was a comment from one group that they thought it would be really good if the supervisor could get more time during the visit with the visitor, and a bit of discussion about how that might work or how you would set it up and find the time.
Thanks, Murray. They're really interesting observations. I think it's all about you walking away from this thinking, this thing happens, the college, holds this as a really, really important aspect of teaching and assessment. How can I make it really maximal value for myself and for the registrar?
Finding out what the registrar might need help with, so what they might be working on or want to work on. Depends what patients come if you get that opportunity, but I think it's really good if registrars, if a visitor says, what are you working on, you and your supervisor, what do you want help with? If they can actually tell you something concrete, I think that's really good. And there's another one about the preparation of registrars before the visit, how you can prepare them for what's a fairly low stake assessment so that they're not really stressed about having someone sitting in, and that might give them the opportunity to see it more as a learning opportunity and get more out of it.
But essentially, Murray and I have had to think about this very, very much with the view of what the supervisor can kind of influence. And in terms of sort of closing the loop, the ECTV happens, there is a visitor-supervisor discussion, which I think usually happens, but sometimes doesn't. And that is, I guess, not ideal, but just understandable when people are busy. There's a report written. I was really heartened to hear the honesty with which one of the supervisors said, I've never seen a report. I didn't really know I could access them. How do I do that? So clearly that's one thing would be strongly encouraging if you're a supervisor who doesn't routinely look at the teaching visit reports to try to avail yourselves of those. And then I guess for more probably less commonly occurring, but something we'd be really keen as an organisation and individuals to encourage, to make sure a supervisor registrar post ECTV happens, and hopefully that's going to lead to enhanced learning. So we have at GPSA put together a document, a resource for supervisors called Maximising the Educational Value of the ECTV, how to make the most of the teaching visit. And it's really looks at 5 areas, and I'm going to unpack these now. It's not rocket science to think these are things that can happen before the visit, during the visit, and after the visit. And essentially this document is meant to be a very practical resource, I guess a little different to some of our teaching method resources where you can actually almost have it as a cheat sheet as you go, because this is going to happen over time, but a resource that you can use to help value add to the visits. And this really is very much a distillation of the conversation that I have had with Murray and to conversations I've had with others over the years as an educator. And much of this is actually very straightforward and quite simplistic in nature, but I guess the observation is that it doesn't always happen. So discussing the visit process with the registrar, I'm a great fan of some of these medical memes that come out, and I love this one. And this is me, and it should say in front of patients, because whenever I try to put gloves on in front of a patient, I end up like that. And this is, of course, the fear of the registrar who's sort of going along okay when nobody's watching, or they think they are, and then they have an observer in the room and it all unravels. And so trying to minimise the nervousness and trying to encourage them to do what they'd normally do and to reassure them that the visitor's actually wanting just to see how they normally practice. Murray, I know this is a big point for you. Have you got any particular other aspects you'd talk about in terms of talking to the registrar in advance?
I think the things I like to say to them are, when you get the invitation, reply to it fairly promptly so the visitor can get organised, and have a think about what we're working on at the moment or what you want to work on, and tell the visitor that early in the visit so that if there's an opportunity in one of the consultations, they can pick up on that and they might have a perspective to share with you. So, if you tell them what you're working on or what you're struggling with, then they can keep an eye out for that and see if the opportunity arises.
Yeah. And I do believe we've got such a powerful role as supervisors here to encourage reflection in the registrar to then talk to their visitor, as opposed to just turning up and seeing how it goes, which is still going to be educationally useful, but nothing like there's been an observation that I'm struggling maybe a little bit with identifying the agenda. that'd be something I'd be really curious to look for today. There's some other very, I guess, straightforward practical things, but reasonable to consider. So again, Murray and I have had some fairly robust discussions about the value or utility or merit of the visitor talking to the supervisor before the visit. I think I've come around to think it's actually a very good thing to be able to do. And then actually practically, it's probably much more likely to happen than after the visit when people are running late and maybe you as the supervisors have gone off to the nursing home or it just doesn't quite work and it's going to be a phone call. So make sure your bookings are okay, make sure you're available, and obviously it's probably something the practice is very familiar with, but around having the visitor in the practice, patient consent, and those sorts of processes. Murray, any other preparation tips?
I love it when the supervisor, when you go to reception and they say, oh, Dr. X would like to see you before the visit, and they introduce themselves and have a quick chat. I'm not sure why, but for me, they tend to be visits that go really well.
Great. As I say, these are not especially kind of innovative, but I think they're worth reinforcing. I like to think of this discussion with the visitor, which we know is part of the visit process, but on occasions doesn't happen. I think we would encourage as an organisation that you as supervisors really drive this and make yourselves available where you can and see this as such an important part. It often happens for 2 or 3 minutes. Everything's going great, fine. I'd see this as the rule of alls. So I put the competency rubric up deliberately because there's 10 domains there. And of course, you're not going to talk about every single one, but think of the registrar across all those clinical domains of practice. Think of improvement in all registrars. I've got this really high-flying registrar. They're doing so well. I'm pushing them to do better and pushing them to identify areas of development. What do you reckon? And ask the visitor where that might go. And of course, all aspects of registrar performance, not just what they did in the clinical teaching visit, but how you see the visitor's assessment of their learning, if there's any personal issues that they've raised, sort of global assessment of the registrars, all the alls. And we've actually developed a document, and it's just a little bit of a template, really. It's maybe something that people don't even want, but, just to have a couple of dot points to work through. Hi, thanks for coming and seeing the registrar. Fabulous. Let's have 10 minutes now, and let's just sort of cover some of these areas. Maybe it's something that you would find quite useful.
I certainly wonder if really good registrars don't get the full benefit sometimes. They seem to be good, and they obviously are. No problems here. They're going to score very highly, no flags. And I wonder if that's a time, sometimes the most fun visits are with the good registrars and you can really push them. And sometimes if I'm pushing them and they look a bit aghast, I say, look, that was fantastic. That was a distinction, but I'm seeing if we can get that to a high distinction. And they sometimes switch on with that and get it and can push them even a bit further. So it's an opportunity for registrars at all levels, I think, if you take it as a teaching and feedback exercise.
Yeah. A little bit of stuff around planning, a little bit of stuff within the visit. And now we're talking about after the visit. And this, I think, is where maybe the real money lies in terms of maximising the educational utility. Because I think we've had registrars in the practice, we know the processes. Hopefully we'll be able to have a bit of a yarn to the registrar in preparation. We all make an effort to talk to the visitor, but maybe there's some things we could do a bit better there. But I think this is where maybe things can change significantly. So one is review of the report. And in some data that we've collected from you guys as part of our national survey, we know it's not universal that you're accessing reports, and I'm sure that's for many, many reasons, but a strong encouragement that the reports absolutely try to access those. And then once you do, obviously, if there's an inconsistency, that might be something that's really important to raise. This registrar is doing really well, and you're thinking, gosh, I've been quite concerned, or the other way around. And clearly, if there's any flags, it would be and is important to have a conversation with the visitor around an amber or certainly a red flag about what's happening. If not the visitor, then certainly it might be the medical educator that you're in contact with. But if you see an amber flag on a report or absolutely a red flag and then nothing comes of that, I think we'd encourage engagement with the college about that.
I think even if a a visitor makes a suggestion to a registrar in a visit and the registrar says, oh yeah, that's a good idea, and you role play it with them quickly between patients, and then maybe they practice it with the next patient. Say it's something like getting the full list out at the start of the consultation.
Yep.
Inevitably, they'll do it for the next couple of consults while you're there. But like all of us, that's really only going to stick if they get consistent follow-up after that. If they don't, like all of us, once you've got your afternoon list and you're busy and you're stressed and you revert to your usual habits, I think, unless there's consistent follow-up to really cement it.
And that's a really nice segue into the second part of this post-visit value adding, and that's having a discussion with the registrar. And again, I think that may happen informally. How did you go this morning? Yeah, good. Seemed to go all right. Or, what sort of things did you cover? But I think trying to make this, maybe carving out some time in the next teaching session or sitting down for the requisite amount of time and actually going through the visit with the report when it arrives, and they should be done in a timely way. I know that's not always the case, but reflecting on the visit, using the report, identifying any areas of concern, areas of strength, thinking about learning needs, I think it's, again, something that I would be really strongly encouraging. So this is touching on many of the rules of feedback around being timely is good, but not always possible. Obviously asking the registrar's reflections on how they thought it went, what observed behaviours. So very much in the report, it was documented that this occurred. How did you feel when that occurred, or that sort of thing. I like this comment. Did anything surprise you about what was said? Were you told you were doing really well when you thought you were just mediocre, or did the visitor make some really interesting suggestions around a consultation skill? And of course, just trying to boil it down to one or two learning points is a really important job for us as supervisors, I think, to say, well, you had 4 hours with this person, but, the one or two really key things that came out of it from what I'm hearing and what the report suggests, agenda identification maybe, and managing the list and prioritising. Something that I think I'm not good at as an educator, as a supervisor, and I think is something that falls away just by virtue of the fact we're busy and life gets in the way. But that's that sort of follow-up. And just the notion of encouraging registrars to say 3 or 6 weeks down the track, you had that visit, we talked about some of the things that came up. How's that changed things? Has it all been forgotten, or have you been practicing maybe that skill, or did you come across any good resources for that? I think it might be useful to encourage registrars to reread the visit report. I'm sure that never happens, but just to look at it a month or two down the track and just say, oh yeah, that's right, those comments were made. Actually, I think I'm doing things differently in relation to that particular aspect of practice as a result. I'm going to quickly whip through some resources. We've had a big revamp of the GPSA website. The contents are the same, but they just look a little bit different. So hopefully many of you know the Consultation Skills Toolkit and teaching plans. They are accessible. They relate very, very closely, obviously, to the teaching visits, because a lot of this is around consultation skills and structuring the consultation. So why am I putting these up? Because I think the teaching visits often refer to these, but you as a supervisor can maybe point a registrar to these resources and say, there's a whole lot of good stuff here, and of course in other locations, to help you rationally prescribe or safety net or manage time, say. We were very excited to launch the consultation game at GPME recently, our latest teaching and learning tool, and a fun one at that. That is based in a lot of role-play encounters, and again, something that you might like to use to reinforce some of the skills that are raised in a teaching visit. We've got a clinical reasoning guide, we've got a how-to guide, so we've got a bunch of stuff, and this is a really common theme that comes out of teaching visits around a registrar's capacity to reason. So again, this is all about you reading this in a report or hearing this from a teaching visitor and thinking, okay, clinical reasoning, I need to take a focus on that. Where might I go? There's, again, lots of places you can go, including the college's own resources, but we've got some stuff too at GPSA. Managing uncertainty, again, very commonly a theme from teaching visit view. And that is mostly it. This is my little attempt at being clever, which I'm not very good at. So I thought we should be proactive, not reactive. There you go. Pretty lame, I know, but that's the teaching visit thing. And I guess this is really just an encouragement as supervisors to, as Murray said, I think really well at the outset, for the registrars, this is this extraordinary opportunity. They can potentially learn a whole lot. They can get a sense of how they're going. And you, as their supervisor, can really maximise this thing too. So I really thank you for coming along. But from all that, I guess encourage you to maybe have a look at that how-to guide and think about the visit before, during and after. And Murray, you've been the driving force. So thank you very much for your advocacy and contributing so fully.
Thank you, Simon. Thank you, everyone who came.
Thank you so much for coming along. I hope that's been useful. Take that away, reflect, think about how you can incorporate it into your practice. Thanks so much.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.